Very good. Hilang Amir.
Okay, can you all hear me?
Yes.
Okay, hold on, because I cannot hear you all for a while. Okay, can you all hear me?
Yes.
Yes, okay. Can you all see my screen?
Yes.
Can all right, okay. Sorry for the technical problem, okay. Assalamualaikum and very good afternoon, everyone. Okay, thank you for the introduction from the Mr. Chairperson. So basically, my name is Nurul Hasana. I am a currently gazetting pathologist in Department of Pathology, SASMEC. So for today lecture, basically I'm giving a topic on a basic pathology, which is on acute and chronic inflammation. Okay, and I think this is a rather basic topic, and I'm sure you all are quite well versed with this topic. So I hope that this will be more like a sharing session and a revision for all of us. Yeah. So as a start, okay, this is the lecture outline of my presentation. So it will be basically two part of presentation, which is on the acute inflammation and followed by the chronic inflammation. Yeah. So to be honest with you, this lecture is actually a 3-hour lecture, but because I was given only 1 hour, I will try my best to actually compress it and give the important point for you all. Yeah? So we start off with what is inflammation. So we all know that the survival of all organisms actually require that they eliminate any foreign invaders such as infectious agents and damaged tissue. And this function are actually mediated by a complex host response, which are called inflammation. So basically, to define inflammation, it is a response of vascularized tissue to infection and damaged tissue, or what we call as cell injury. And it is also a protective response, which are essential for survival. And intimately, it is associated with repair process. So if you still remember this diagram, okay, the connection between the tissue injury, the death, and the inflammation. So every time when there is a tissue injury, yeah, be it by an infectious agent or other stimuli, it will cause some matrix damage or a necrotic cell death or even apoptotic cell death, yeah. So with the production of the host products and the microbial products, okay, our body will detect this, okay, and it will initiate the process of inflammation. So it's basically our body response, yeah, toward the injurious agent. So the purpose of inflammation is basically to bring the cells and molecules from the circulation to the site of the injury, yeah, and also to eliminate agent or cause of cell injury, and somewhat they also help to clear the necrotic cells and the tissue which arising from the injury, and finally to help initiate the repair process. Okay. So the type of inflammation that we have are basically two types, which are the acute and the chronic inflammation. And both type of inflammation can readily be distinguished from a few features, yeah, as I highlighted in this table. So when we talk about acute inflammation, so we are talking about the onset, which are very fast, within minutes or even hours, yeah, as compared to chronic inflammation. Usually the onset can be rather slow, rather gradual, yeah, it can take even days to months or even years, yeah. And then the type of cells that are involved between these two inflammation are also different. In acute inflammation, the cells are more of a polymorphonuclear, especially the neutrophils. But in the chronic inflammation, they are more of a mononuclear cells like monocytes, macrophages, and lymphocytes. And the other factor is including the tissue injury or fibrosis. Usually in acute inflammation, the injury will be rather mild, okay, and self-limited. So we can't really see any destruction of the surrounding tissue. As compared to chronic inflammation, the destruction can be rather severe and progressive, yeah. And in terms of the local and systemic signs, usually the acute inflammation, they will have a very prominent signs and symptoms that usually the patient present with. But in chronic inflammation, this will be less, yeah. So the causes of inflammation, okay, the general causes, it can be divided into infective causes, okay, or when there is tissue necrosis, regardless of the causes, all right, any foreign body, whether it's endogenous or exogenous, and when there is any hypersensitivity reaction, yeah. Typically in acute inflammation, there will be related to the hypersensitivity reaction type 1, okay. So now we proceed to the first part, which is the acute inflammation. Okay, I have mentioned this earlier. Okay, it is transient, early response to injury, and usually characterized by release of chemical mediators. And it leads to the response of the vascular as well as the cellular response. So here, as you can see clinically, acute inflammation will show a very evidence in terms of the sign and symptoms. Yeah, for example, in the first picture, okay, blister formation from the maybe injury from the thermal or burn. Okay, and then patient may present it with erythematous, you know, as well as swelling. Okay. So these all are basically the cardinal features of acute inflammation. If you still remember the 5 cardinal features, okay, the calor, the rubor, tumor, dolor, and functio lassa, yeah. Okay. So again, the stimulus to acute inflammation, as I have mentioned earlier, all right, and the major component of acute inflammation, okay, sorry. So the major component is a vascular component. Okay, it will have an exudative component, cellular component, and as well as the proliferative component. And we will look at this one by one. So in terms of sequential vascular events, so there are few events that occurring in the vascular events, yeah. So the first one is actually transient vasoconstriction. So in transient vasoconstriction of the arterioles, okay, this is the most immediate response to injury. Okay, it is rather transient and sometimes maybe not significant at all. And neurogenic reflex can last seconds, and this will be followed by persistent vasodilatation of the arterioles, okay, whereby there will be active dilatation of the arterioles, the capillaries, and the venules, okay. And histamine and other vasodilators will help to relax the vascular smooth muscle, which actually cause increase in the blood flow to the area of the injury. So this clinically presented as the redness or erythematous and also the warm feeling at the site of the inflammation. So when there is increase in blood flow, okay, this will actually lead to the increase in the local hydrostatic pressure, which actually will cause transudation of fluid into the extracellular space, yeah, okay. Okay, number 3, there will be increased permeability of the venules, okay. The histamine and other mediators will actually contract the endothelial cells in the venules, okay, producing an endothelial gaps or exposing the bare basement membrane, yeah. Okay, next will be the swelling of the tissue or what we call as edema. So when there is exudation of protein-rich fluid, all right, decrease in the intravascular osmotic pressure and increase in the osmotic pressure of the interstitial fluid will cause the outflow of the water and the ions, okay? So this will lead to the swelling or the what we call as edema. So due to the net outflow of fluid from the venules, which surpasses the capacity of the lymphatic to remove this fluid, so it will retain the fluid within the extracellular compartment and reduce in blood flow, okay, due to the outflow of the fluid into the interstitial tissue and increase the uptake of fluid by the lymphatics, right? Okay, so in the diagram here, okay, as I have described earlier, you can see when there is a normal vessel, okay, it is a rather normal. When there is inflammation, what will happen is that there will be increase in blood flow and vasodilatation of the vessel, yeah. So with this vasodilatation and increase in the vessel permeability, okay, this will actually cause fluid and plasma to go to the extracellular spaces, all right? And this process also help to emigrate the neutrophil or the leukocytes, okay, to the site of the injury. Right. So normally, the fluid leaving and entering the vessel are actually in equilibrium, all right? But when there is acute inflammation, like I mentioned earlier, there will be a net loss of fluid together with the plasma protein molecules into the extracellular spaces. So this what causes edema to occur. So basically, how do the vessel become permeable? So there are few ways how this vessel become permeable, yeah. The firstly, maybe because of the endothelial cell contraction. So basically, when there is chemical mediators of acute inflammation, it will lead to the active contraction of the actin filament of the endothelial cells, which actually open the transient pores. So this causes the capillary leakage. Other way basically maybe through the direct endothelial injury, okay, when there is endothelial cell necrosis and detachment, such as for example due to severe injury or burn, okay, it can occur immediately and last until the vessel is actually repaired. Or the permeability can be due to the leukocyte dependent injury, okay, usually at the site of leukocyte accumulation. Okay, the activated leukocyte release proteolytic enzyme and also toxic oxygen radical. And this enzyme and radical can cause harm also to the host cells and tissue, okay? And when there is increased transcytosis, okay, for example, within the intracellular augment venular permeability after exposure to mediators, okay, like when it is exposed to the VEGF, which is the vascular endothelial growth factor. So this can also lead to the increase in the vessel permeability. Yeah? And finally, the new vessel formation. Okay, usually when there is newly formed vessel, okay, this vessel will remain leaky until it become mature enough. Yeah, so these are all the factors that can cause the increase in the permeability of the vessels. So how about the cellular events? Okay, as I mentioned earlier, in acute inflammation, the important thing that occur you have to remember is the vascular changes as well as the cellular events. So the two main process you have to remember is exudation of the leukocytes as well as phagocytosis. So in terms of exudation of the leukocyte. So how does this leukocyte actually escape into the interstitial tissue, or what we call as the leukocyte migration? So the process that involve are basically when there is changes in the blood, margination and rolling. Okay, we will look into this one by one. So the first one is the changes in the vessel. So when there is vasodilatation of the blood vessel, right, this will actually lead to the stasis of the blood all right, there will be disruption of the normal axial blood flow, okay, or the central stream of the cells. And due to the plasma loss during the exudation, it will further disrupt the flow, okay. So with the sizes, okay, the sizes of the leukocyte are basically much larger than the red blood cells. So the leukocyte will be dispersed to the periphery of the blood vessel. Yeah, it will become close to the vessel wall, okay, or what we call as the pavementing space. All right. Okay, so this is when the recruitment of this leukocyte will occur. So the sequence of events that bring the leukocyte from the vascular lumen to the extravascular space involve a few phases, which is margination and rolling, addition and transmigration, and also the chemostaxis. So for margination, okay, it's actually the process whereby the leukocyte will accumulate at the periphery, yeah, okay, at the periphery of the endothelial lining of the blood vessel, right? So it is enhanced by the laminar flow that swept the smaller red cell to move faster than the larger white cell. So the white cell will be left at the periphery, at the peripheral, okay, of the blood vessel or the endothelium. So as the result, okay, this will give a better opportunity for this leukocyte to actually interact with the endothelium, especially during the stasis, yeah. So this will lead to the next phase, which is the rolling and the addition. So in the rolling phase, what happens is that, okay, this leukocyte, okay, it's marginate and roll over the endothelial, yeah. The movement is done by the presence of this receptor, or what we call as the selectin receptor, on the surface of the leukocyte, okay, which will bound to the receptor on the surface of the endothelial cells, okay, so it will roll. So once it's rolled, it will adhere, okay. The leukocyte will actually adhere to the endothelial cells. All right, and by the help of this ICAM, which is the intracellular adhesion molecules, it will help to localize the leukocyte to the site of injury and proceed to the next phase of transmigration of this leukocyte. So in terms of emigration, once it's already adhered to the endothelial cells, all right, so by the assist by the PCAM1 molecules, all right, it will help this leukocyte to actually pass through the basement membrane, yeah, okay, with the presence of collagenase enzyme which degraded the basement membrane layer. So this leukocyte can actually escape into the extravascular spaces, yeah, all right. Okay, and escape of the RBC, or what we call as the diapedesis, right? Diapedesis is basically the passage of blood cell through the intact wall of the capillary, okay? Usually this process accompany the inflammation. So this is just a diagram to summarize what I have explained earlier to you, all right? The process of this emigration of leukocytes. So how about chemotaxis? So the role of chemotaxis is basically, it is a chemotactic factor which mediates the transmigration of leukocyte to reach the interstitial tissue or the site of injury. So a few examples of chemotactic factor are our complement component, all right, chemokine and cytokine and so on. So the next cellular changes that we will look at is basically the phagocytosis, all right? The phagocytosis basically mean engulf and destroy. So the engulf particle is actually destroyed by degranulation and the oxidative burst that occur within the cells, yeah? So the main cell that can do this function is basically the neutrophils and the macrophages. And these are basically the first step that involved in phagocytosis. So here again, to summarize to you, okay, you have to remember in acute inflammation, the important thing is basically the vascular event that occur and also the cellular event that also occur. And as you can see, listed at the side here are basically all the mediators that involved in this inflammatory process. Yeah, and we will look at a bit in detail. Yeah, so what is mediators of inflammation? So basically, they are the substances that initiate and regulate the inflammatory reaction. Okay, they are basically chemical agents that intensify the inflammatory process, and they can be divided into various groups. Okay, as we know, we have the vasoactive amine groups. Okay, like histamine and serotonins. Yeah, their main effects, okay, of this histamine and serotonin is for vasodilation and also for increase in the vascular permeability. And then we have our prostaglandin and leukotrienes, which are involved in the vascular reaction as well as in the leukocyte chemotaxis. Yeah. And okay, what about cytokines? Cytokines are basically protein that are produced by many cell types. Yeah, usually it have a short acting range. Okay, they actually mediate the multiple effect, mainly in the leukocyte recruitment as well as migration of the leukocyte to the area of the injury. Yeah. For example of cytokines, that usually the principal one in acute inflammation is tumor necrosis factor, interleukin 1, interleukin 6, as well as chemokines. Yeah. Okay. So they are the most of these mediators are actually short-lived. Okay, they are actually in inactivated form. Okay, in the circulation, and they control and limits inflammation and harmful effect of the inflammation. So their action are through a few various methods, whether they can bind to specific receptor on the target cells, or they can cause a direct enzymatic activity, for example, lysosomal protease, or they can even mediate the oxidative damage, such as the oxygen radical species. Yeah. And the source of this mediator, we can divide it into a plasma-derived or the cell-derived. Usually, if it's plasma-derived, it is synthesized by the liver, all right, and released into the circulation, and it has to be activated. As for the cell-derived, usually it is preformed and synthesized within the cells itself. Yeah. So these are basically, you can read later. I have divided the type of mediators based on whether they are plasma-derived mediators or they are actually the self-derived mediators. Yeah. So let's talk about a little bit about interleukin 1 and tumor necrosis factor, because they are actually the main mediators that involved in acute inflammation. So when there is bacterial product, okay, or any immune complexes or toxins, okay, this will cause activation of macrophages, which will secrete the interleukin 1 and the tumor necrosis factor. So this tumor necrosis factor and interleukin 1 will have a few effects. Yeah, for example, yeah, basically the acute phase reaction. Okay, they can cause fever. Okay, increase in sleepiness, reduce in appetite. Okay, and they can lead to increase in the acute phase protein. And at the same time, they also have effect on the endothelial. Yeah, sorry. And also the fibroblast effect as well. Okay. So here I have, okay, I have actually prepared the the table of the mediators of inflammation, which you all can actually read later. Yeah? So basically, there are many types, many types of mediators. Okay, sorry. So basically, there are many types of mediators, and they have different mode of action. So now we will go to the types of acute inflammation. So the first one is basically the serous inflammation. So in serous inflammation, it is marked by fluid exudation or effusion. Yeah. For example, when there is a skin blister or conjunctivitis, okay, microscopically what we can see is basically the epidermis is separated from the dermis by a focal collection of serous fluid. And then the next one is basically okay, the next one is the catarrhal inflammation. Okay, this is basically due to mucus hypersecretion. Example in common cold. Okay, and then we have the hemorrhagic inflammation, usually associated with severe vascular injury, for example, in acute pancreatitis. Yeah. So because in acute pancreatitis, the pathophysiology is there is an auto-digestion by inappropriately activated enzymes, isn't it? So this enzyme will actually activate clotting and the complement system, which will lead to sort of like a vascular injury lah, okay, to the organ. And then we have the fibrinous inflammation, okay. It is due to the fibrinous exudate formation. The inflammation usually occur at the lining of the body cavities, all right. And the fibrin is deposited due to the vascular permeability, okay. So you can see here as in the picture. So the pink meshwork here is basically how the fibrin deposition look like, yeah. Okay, and the P here is the pericardial surface. So grossly, this is how a fibrinous pericarditis can look like, okay. We describe it as like a bread and butter appearance. Huh? So we can see here. All right. So another type of acute inflammation is what we call as the suppurative or the purulent inflammation. So in this type of inflammation, usually there will be large amount of pus produced, okay. And this pus actually containing neutrophils, okay, necrotic cells and edema fluid lah. All right, so we proceed for the clinical sign of acute inflammation. So in terms of clinical manifestation, all right, clinical indication of inflammation, usually patient will present with malaise or fever, yeah, because this actually basically the response of the systemic effect of the inflammation, yeah, fever, malaise, okay. The pain is usually localized in acute inflammation, okay. So patient may also have a rapid pulse rate due to the vasodilatation and increase in blood flow, okay. The heart has to pump faster, and when we do the lab investigation, usually we will do a full blood count. We can readily see that the neutrophils will be markedly raised, yeah, because neutrophils are the main cellular component that play the main role in the acute inflammation. There will also be increase in the erythrocyte sedimentation rate, yeah, because in inflammation, we know that there will be fibrinogen, you know, fibrinogen will enter the blood in a very high amount. So this fibrinogen will actually causes the red cell to stick to each other, right? So this actually what leads to the increase in the erythrocyte sedimentation rate. Apart from that, there will also be increase in the concentration of acute phase protein, such as the C-reactive protein. Yeah? So what are the effects of acute inflammation? Basically, it has a beneficial effect as well as a harmful effect. In terms of beneficial effect, it helps to dilute the toxins, okay? It helps in the entry of the antibodies to the site of injury and transport of drugs, okay? When there is a fibrin formation, it impedes the movement of the pathogen and facilitate the process of phagocytosis. And it also helps to deliver oxygen and nutrients to the site of injury as well. And another thing is that it helps to stimulate the immune response, okay? And then there will be drainage to lymphatic to reduce the edematous fluid. However, when there is severe inflammatory reaction, okay, especially when there is a infectious agent involved, the transport of this offending agent within the lymphatic channel actually contribute to its dissemination. All right, so it can cause a secondary inflammation to the lymphatic channel, as we call lymphangitis, and it can also cause inflammation of the lymph nodes, as we call the lymphadenitis. Yeah? As for the harmful effect, it can lead to digestion of normal tissue, for example, the production of collagenous enzyme just now, and inappropriate response, for example, in hypersensitivity type 1, yeah? So it can cause harmful effect to the host cells as well. So the outcome and sequelae of acute inflammation generally can be divided into 4, right? So the first one is actually complete resolution. So in complete resolution, it is a usual outcome when the injury is rather limited or short-lived, okay, and it will cause a little tissue destruction or death, and damaged parenchymal cell usually can regenerate, okay. It have a rapid clearance of the causal agent and rapid removal of fluid and debris by a good local vascular drainage, for example, in acute pneumonia. So sometimes acute pneumonia, a patient can have a complete resolution. The next outcome will be suppuration, or what we call as the formation of pus. So the outcome occur when the injury is rather persistent or virtually always due to infective agent, especially when it is pyogenic bacteria. Yeah? So once the pus is surrounded by a membrane, that's what we call as a abscess formation. And usually it's quite difficult for the accessible to the antibiotic and the antibodies. And the third sequelae will be healing by connective tissue replacement, or what we call as fibrosis. So it occurs when the injury results in substantial tissue destruction and death, or when it involves tissue incapable of regeneration. So when it cannot regenerate, so it will be replaced by fibrosis. Yeah. So there will be abundant fibrin exudation and difficult to remove, and exudate and debris cannot be removed or discharged. So usually in this type of sequelae, it occurs in when the inflammation involving cavities. Okay. And finally, the fourth one, it can progress to chronic inflammation. Yeah, so this can occur when the acute inflammatory response cannot be resolved, maybe due to persistence of the injurious agent, or when there is interference with the normal process of healing, or when there is organization and change of predominant cells infiltrate. Yeah. So this is just to summarize the consequence of acute inflammation. Okay, so now we can proceed to chronic inflammation. Before that, is there any question, everyone? Is it okay? Okay, I'm sorry for the disturbance just now. So we proceed to the chronic inflammation. So as compared to the chronic inflammation, okay, the inflammation are usually prolonged duration. Okay, it can take weeks to months or even years, in which there will be active inflammation, tissue injury or destruction, and healing process occur simultaneously. Yeah. So it can occur by two mechanisms. Okay, number one, following an acute inflammation. All right. So due to the failure to resolve the acute response, okay, or when there is persistence of the injurious agent, or when there is interference of the normal process of healing. So this can lead from acute inflammation will become chronic inflammation. Yeah. Or another mechanism is from the onset of some injury. So this type is basically what we call as the primary chronic inflammation. So it is something that is readily chronic in the first place. Yeah? It doesn't start from acute process. So it is rather begin insidiously as a low grade or smoldering and asymptomatic response. For example, of disease as you can see here, like in rheumatoid arthritis or atherosclerosis or TB. Yeah. So, and here I would like to highlight the example of progression from acute inflammation, for example, in chronic abscess osteomyelitis. So when you have a pus forms an abscess cavity, which is rather deep-seated, so there will be delayed or inadequate drainage of this abscess. Yeah. So because of that, there will be thicker wall of granulation tissue and fibrous tissue formation. So the pus will become stagnant, organized with an ingrowth of the granulation tissue. So it will be replaced by a fibrous scar. Yeah? So that's how chronic abscess osteomyelitis actually developed from the acute osteomyelitis. So apart from that, chronic inflammation can also arise in the following setting when there is a persistent infection by microbe that have a low toxicity. Okay, because of this low toxicity, it actually evoke delayed type hypersensitivity, or what we call as type 4 hypersensitivity. For example, in the case of Mycobacterium tuberculosis. Yeah. Or maybe when there is an autoimmune diseases, okay, like in rheumatoid arthritis or SLE, there is an autoantibodies against the host own cells. Yeah. And when there is a prolonged exposure to toxic agent, this one can either be an endogenous, all right. If it's endogenous, the example can be like toxic plasma lipid component, which lead to chronic inflammation of the arterial wall that lead to formation of atherosclerosis. Or when exogenous, for example, when there is a non-degradable material which are inhaled for a prolonged period, okay, this can actually result in chronic inflammatory lung disease. For example, inhalation of silica that can lead to silicosis. Yeah? So in terms of feature of chronic inflammation, it can really be distinguished from the acute inflammation, all right? Because the important features that you have to see is basically the mononuclear cell infiltrate, right? Because it involves macrophages, lymphocyte, and plasma cells. All right, there will be evidence of tissue destruction because of the chronicity of the disease. Yeah? And then there will also be evidence of attempt of healing by fibrosis and formation of new blood vessel by the process of angiogenesis. And in certain condition of chronic inflammation, you can see the granulomatous formation as well. And we will look into detail in this type of inflammation. Yeah? So, okay, the first features of chronic inflammation is basically the mononuclear cell infiltrate, all right? And the dominant cells in chronic inflammation will be the macrophages, yeah? So, monocytes, okay. These macrophages actually derive from monocytes, okay? Monocytes actually start to emigrate from the blood vessel within 24 to 48 hours of the onset of inflammation. So it will be activated by variety of stimuli. Okay. So once this monocytes is emigrate into the area of injury, okay, it transforms into macrophages. So these macrophages, once activated, it will become bigger in size. Okay, it has an increase in the lysosomal enzyme, more active metabolism. It has a greater ability to kill ingested organism. And also it can secrete variety of active products such as the cytokines, the proteases, and all these factors will help these macrophages in killing of the offenders or the injurious agent. Okay, for example here, all right, just to show to you, okay, that our macrophages actually derive from monocyte. Okay, so the starting of this monocyte, it is actually produced from the stem cell in the bone marrow, okay, into monoblast, whereby when it is released into the blood circulation, okay, we call it as the monocyte. Yeah. So this monocyte, when it entered the tissue, all right, or the extracellular matrix, okay, it will be called as the macrophages. Okay, so this macrophages has a few different names depending on where these macrophages are located. Okay, it have other names to it. Okay, so these macrophages, when it become activated, it will become enlarged and it will contain all the increase in the lysosomal enzyme uh, for the process of phagocytosis and so on, yeah, lysosomal enzyme. So the next cell that involved in the chronic inflammation is basically lymphocyte. So lymphocyte mobilization occur in both the antibody mediated and cellular mediated immune response. It is actually recruited by the release of cytokine from activated macrophages. So when activated macrophages at the inflammation site, it will give signal, okay, to recruit more of the other mononuclear cells, including lymphocyte. Okay, and its function to recognize the antigen peptide presented by the antigen presenting cell or macrophages, okay, via the MAC class 2, okay, and it will become activated. So when this lymphocyte is activated, it will release the interferon gamma, which in turn will activate more macrophages, and at the same time, if the B lymphocyte is activated, it will produce antibody. Yeah. So just to highlight, okay, collection of these antigen presenting cell and macrophages, as well as lymphocyte and plasma cell, resembling the feature of lymphoid organ, and this frequently seen in the case of long-standing rheumatoid arthritis. So basically like a feature of chronicity of the disease. Yeah. So other than that, we have eosinophils. So eosinophil usually it is recruited by eotaxin, okay, and it is it is abundant in the parasitic infection. Okay, this is because the granules that contain within the eosinophils, okay, it has a major protein that is toxic to the parasite. Other cells include the mast cells, yeah, mast cells, okay, are the one that release the histamine. So another cell that may be of importance is basically neutrophils. Okay. Despite the neutrophils are the main cell in the acute inflammation, but in chronic inflammation, neutrophil can also be found. Usually in chronic inflammation that involve the smoking lungs, yeah, the irritant will promote the neutrophils infiltrate and lead to chronic damage to the lung parenchyma. So basically, in chronic inflammation, okay, what will happen is that, okay, the formation of tissue destruction. So when the monocyte from the blood circulation emigrated from the vessel into the extravascular space, okay, it will transform into macrophages. So it will be activated by the activated lymphocyte at the site of inflammation. So this activated macrophage will become larger in size and have all the increase in the lysosomal enzyme. It has a more active metabolism and greater ability to kill the organism and secrete a variety of active mediators or products. Yeah. So this will help engulfment, digestion, and killing of the offender. But if the inflammation is short-lived, okay, and the offender is eliminated, these macrophages will die off or making it way to the lymphatics, all right? However, if the inflammation is perceived, the recruitment of more monocyte from the circulation to become macrophages under the influence of the chemokine, which are produced by these activated macrophages and lymphocyte, will cause local proliferation of the macrophages and immobilization within the site of inflammation. And the proliferation, accumulation, and immobilization of these activated macrophages enhance the attempt of killing of the offender. But at the same time, this will also lead to the tissue destruction. Okay, so in terms of morphologic features, okay, if we look under microscope, basically in chronic inflammation, we will look for infiltration by these mononuclear cells, all right, and look for the evidence of tissue destruction and also the attempt at healing by connective tissue replacement, okay, by proliferation of small blood vessel, angiogenesis, as well as the fibrosis. So we will look for evidence of granulation tissue formation and fibrosis as well. So this is just to demonstrate, okay, the difference in terms of microscopic finding between acute and chronic inflammation. So at your left-hand side, okay, this is basically the chronic inflammation in the lung, okay, showing all the three characteristic histologic features. So number one, you can see collection of these chronic inflammatory cells, okay, this more bluish, darker bluish color, okay, at the right-hand side. All right, with the destruction of the parenchyma. So you see that there is actually loss of the normal alveoli architecture because it is actually replaced by a cuboidal epithelium. And at the same time, you can see replacement by connective tissue or the presence of fibrosis. Yeah, as compared to your right-hand side, okay, this is an example of acute inflammation of the lung, okay, acute bronchopneumonia. You can still readily see the normal architecture of the alveolar spaces. Yeah, so you can see here alveolar spaces, but these alveolar spaces are basically filled with neutrophils. So it indicates acute inflammation, isn't it? Neutrophil, prominent neutrophilic infiltration. And at the same time, you can readily see, okay, a lot of this red color. These are all the congested blood vessels. So basically, there are evidence of the vascular changes as well as the cellular infiltration. So other macroscopic appearance of chronic inflammation can readily be seen, for example, in chronic ulcer, okay, when with chronic abscess cavity, okay. For example, in Crohn's disease, when there is thickening of the wall of hollow viscus, okay, due to the formation of fibrosis, okay. Granulomatous inflammation is one of the macroscopic features of chronic inflammation in certain diseases, okay. And also when there is prominent fibrosis, for example, in chronic cholecystitis, okay, and Crohn's disease, okay. Okay, so now we go into the last part, yeah, which is the granulomatous inflammation. So granulomatous inflammation is actually a form of chronic inflammation, but it has a distinctive pattern, yeah. It is basically characterized by focal accumulation of activated macrophages, which often develop an epithelial-like or what we call as epithelioid appearance. So what is actually a granuloma? So we define granuloma as a focus of chronic inflammation consisting of a microscopic aggregates of macrophages, all right, but these macrophages already been transformed into epithelium-like cells, or what we call as the epithelial cells. So usually we will say aggregate of epithelial cells surrounded by a collar or a rim of mononuclear lymphocytes, okay, principally usually lymphocyte and sometimes plasma cells. Yeah, we will see the microscopic picture. So there are basically two types of granuloma which differ in terms of pathogenesis. So when we say in terms of pathogenesis, we divide it into foreign body granuloma. Okay, foreign body granuloma are basically incited by the presence of innate foreign bodies such as the tox, okay, or the sutures or other fibers. Okay, and the granuloma are usually large. Okay, and it cannot be phagocytosed by a single macrophage, and usually it do not incite any specific inflammatory or immune response. Yeah, so that's what we call as a foreign body granuloma. But another type of granuloma is what we call as the immune granuloma. So immune granuloma, they are caused by insoluble particles, okay, typically microbes, all right, or infectious material that are capable of inducing cell-mediated immune response, okay? And this cell-mediated immune response does not necessarily produce granuloma. It does so when the inciting agent is fully degradable, for example, in Mycobacterium tuberculosis cases, yeah? So what actually happened is that the macrophages will engulf the foreign material and process, and it will present it to the T lymphocyte. So this T lymphocyte is activated, it will produce cytokines, okay? So when it produces interleukin-2, this interleukin-2 will activate other T cell, okay, to perpetuating the response. But if it's produced interferon gamma, okay, this interferon gamma is actually important in activating these macrophages and transform them into becoming the epithelial cells. And when they aggregate together, they will become the multinucleated giant cells. Yeah? So in terms of morphological type, just now we are talking about the pathogenesis type. Yeah, so this one is the morphological type. So there are also different morphological type of granuloma. The first one that we usually talk about is the caseous granuloma. So caseous granuloma, basically the name comes from the central caseous necrosis, all right, which usually can be found. Okay, so the inner layer of this granuloma is basically the epithelial cells with scattered multinucleated giant cells. Yeah, okay, this multinucleated giant cell may or may not be present. Yeah, and then the middle layer will be the lymphocytes, and finally the outer layer are usually predominantly the fibroblasts, which try to constrain constrain the infection. Okay, within the granulomatous focus. Okay, and then caseous granuloma are basically granuloma with central necrosis, right? Or we call it as caseous necrosis. And this type of granuloma is typically seen in Mycobacterium tuberculosis infection. Okay, and it is rather rare in other granulomatous diseases. That's why when we see a granuloma formation, especially when it is a caseous granuloma, the first thing that we have to exclude is basically the TB infection. Okay, so this helps to facilitate diagnosis of this common infection based on the morphological appearances. Okay, so this microscopically, this how it will look like. Okay, it might not be exactly like the diagram just now, but you can see. Okay, at the center here is the central necrosis or the caseous necrosis area. With the surrounding here are basically the epithelial cells. Yeah, the epithelial cells. Okay, the cells are rather spindle to slipper shape. Okay, and it has these scattered multinucleated giant cells. And one thing about this giant cell, if you see nicely that the nucleus is arranged peripherally, yeah, like so what we call as the Langhans type giant cells, which is very typical of Mycobacterium tuberculosis infection. And then we also have other type of granuloma, which actually the non-caseous granuloma. For example, in the case of sarcoidosis, okay, in the case of sarcoidosis, it is non-caseous, so you did not see any central caseous necrosis, all right, but you still have these aggregates of epithelial cells, okay, with this foci of multinucleated giant cells, okay, and it is surrounded by a rim of lymphocytes. And another type of giant cell is the foreign body type giant cells, yeah. So this is just again the Langhans giant cell type. Okay, it has a horseshoe shape, very nice. So basically, I think that's the last slides. Okay, the last slide of my presentation.
I think, thank you, Dr. Nur Hassan. Is there any question from the participant from online or in the room?
Good presentation.
I'm very sorry for the disturbance of my coughing. I'm very sorry, yes.
We end our session. Is there anything you want to add, Dr. Hassan?
Okay, I would like to say thank you to everyone, okay, for listening to my presentation. Just so-called like a take-home message, okay. Basically, just remember that acute inflammation, you stress on more on the vascular changes as well as the cellular event that occur, yeah, as compared to the chronic inflammation. What you have to remember is just the three hallmark, okay, which is the mononuclear infiltrates, the evidence of tissue destruction, as well as the healing process, or the formation of the fibrosis and angiogenesis, okay. And another important thing you have to remember is the granulomatous inflammation, okay. Right.
All right, thank you very much, Dr. Nur Hassan.
Okay, thank you so much.
Thank you, Radha.
Thank you.